Hi guys, welcome back to my channel. And in this video, I'm going to talk about cholinergic agonist. So before talking about the cholinergic agonist, I want to talk about the cholinergic receptors. So there are two types of cholinergic receptors. There is muscarinic receptor and there is nicotinic receptors. Muscarinic receptors are M1, M2, M3, M4, and M5. This is the subclass of the muscarinic receptor, and there is the NN receptor and the NM receptor. These are the nicotinic receptors. First, let's talk about the muscarinic receptors. Here we have the M1 receptor. I'm going to talk about the type of these receptors, their sites and action. Okay. So, M1 receptor is a GQ type of receptor, and the site where they are located is autonomic ganglia. Okay. Autonomic ganglia, then they're located in the gastric glands. In gastric gland, it increases the release of histamine, and that leads to increase. So there is the parietal cell, and when histamine acts on the parietal cell, they increase the acid secretion from the parietal cell into the gastric lumen. Okay, acid secretion or ACL secretion, we know. They're also located in the lower esophageal sphincter. And in the lower esophageal sphincters, they causes relaxation of the lower esophageal sphincter. Okay, then we have the M2 receptor, which is GI type of receptor, and this is mainly located in the cardiovascular system. In the cardiovascular system, we have the SA node, where it causes decrease in heart rate. By acting on SA node, it decreases the heart rate. It also decreases or slows the AV conduction, and it decreases the force of contraction. So it gives negative inotropic effects. Okay. Then we have the M2 receptor, and M2 receptor is a GQ type of receptor, which is mainly located in the visceral smooth muscles. Okay. And also in the bronchial smooth muscle. So in the bronchial smooth muscle and the visceral smooth muscles, they causes the contraction. Okay, like GI contraction, and increases the GI motility and the bronchial smooth muscle contraction. M3 receptor is also located in the vessels, and we have this in the endothelium of the vessel. And from endothelium, it releases the endothelium derived relieving factors, and this causes the vasodilation. Okay. We also have M2 receptor in the ciliary muscle of the eye. Ciliary muscle of the eye. And in the ciliary muscle, it causes the contraction of the ciliary muscle. and this loosens the suspensory ligament leads to bulging out of the lens, and it causes accommodation for the near vision. Okay, and we also have the M4 receptor and the M5 receptor. M4 receptor is a GI type of receptor, and this is mainly located in the CNS neurons or central nervous system neurons. And M5 receptor is the GQ type of receptor, and it is located in the vascular smooth muscles. Vascular endothelium. Okay. Especially the cerebral vessels. Then we have our nicotinic receptor. This is an M receptor and an N receptor. So an M receptor is located in the skeletal muscle end plate. And an N receptor is located in the ganglionic cells. So our main topic of today is cholinergic agonists. We have two types of cholinergic agonists. There is directly acting cholinergic agonist, and there is indirectly acting cholinergic agonists. So in directly acting cholinergic agonists, we have muscarinic agonists, and there is the nicotinic agonists. So we will talk about the muscarinic agonist in this video. So muscarinic agonists can be classified again into cholinesters. They are the esters, and there are the alkaloids. Okay. So what we have in the cholinesters is acetylcholine. Then we have the methacholine. Then we have bethanicol and carbachol. Okay. In alkaloids, we have muscarine and pilocarpine. Okay. So directly acting cholinergic agonists. So why we call it directly acting cholinergic agonist, and why there is an indirectly acting cholinergic agonist? So if we look at the mechanism of action of these drugs, this directly acting cholinergic agonists directly act on the muscarinic or nicotinic receptors. Okay, so they directly act on the muscarinic receptor or nicotinic receptor. But the indirectly acting cholinergic agonists, which we will talk in another video, but the mechanism of action of indirectly acting cholinergic agonists, that there is an enzyme called acetylcholinesterase, and they break down the acetylcholinesterase. So acetylcholinesterase break down the acetylcholine, and they decrease the effects of acetylcholine on the cholinergic receptors. But by inhibiting the acetylcholinesterase, indirectly acting adrenergic agonist increases the concentration of acetylcholine in the synapse. So by increasing the concentration of acetylcholine, they act as a cholinergic drug. Okay, so let's see the pharmacological effects of directly acting cholinergic agonists. So what is their effects in the eye? So in eyes, they cause meiosis cause there is the AMP receptor in the constrictor pupillae muscle. So there is the dilator pupillae and there is the constrictor pupillae. Okay, the radial muscles, or I can say that radial muscles and the circular muscles. So we have in the circular muscle, the constrictor pupillae, this M3 receptor, and acting on the M3 receptor, acting on the M3 receptor, they constrict the constrictor pupillae, and the size of the pupil will get smaller and smaller, and it will lead to meiosis. Okay, then in the ciliary muscle, we have already talked about that. In the ciliary muscle, that causes the contraction of the ciliary muscles, and that leads to bulging out of the lens. And when the lenses are bulged out, okay, so let's see that there is the eye, okay, and this is the ciliary muscle. There's the ciliary muscles, and this is the lens, and this is the suspensory ligaments. Okay, so when this ciliary muscles contract, okay, this suspensory ligaments gets loosened. Okay, and when this suspensory ligaments gets loosened, this lens bulge out. Okay, and when this lens bulge out, there is accommodation for the near vision, or accommodation for near vision. There is another thing that these drugs decreases the intraocular pressure. So how they decrease the intraocular pressure? If we again look at this picture, that's in this diagram, that when the ciliary muscles contract, there is the trabecular meshwork. Okay, so there is the trabecular meshworks, and beneath the trabecular meshwork there is the canal of Schlemm. Okay, through the canal of Schlemm, the aqueous humor drains. Okay, so, and this is the lens. So when the ciliary muscle contracts, let's see that when the ciliary muscle contracts, this trabecular meshwork gets loosened. Okay, so this trabecular meshwork gets loosened. When this trabecular meshwork gets loosened, this aqueous humor can easily drain into the canal of Schlemm, and this leads to the decrease in intraocular pressure. And so that we use the drug called pilocarpine in glaucoma. And we used it in the open angle glaucoma. So we can use it in close angle glaucoma. So there is no effect of pilocarpine on closed angle glaucomas, because when the canal of Schlemm is already blocked, then it can't, or aqueous humor can drain into the canal of Schlemm. So there is no effect of contracting the ciliary muscles or relaxing the trabecular meshwork. So we will not use it in close angle glaucoma, and we use pilocarpine in the open angle glaucoma. Okay. Then let's see their effect in the cardiovascular system. So in the cardiovascular system, we have the M2 receptor, and it is a GI type of receptor, and this leads to decrease in the adenylyl cyclase, and this leads to decrease in the cyclic AMP. Okay, so what it does is, by decreasing the cyclic AMP, it increases the potassium current in SA node and AV node. Okay, so by increasing the potassium current in SA node and AV node, it causes hyperpolarization of the SA node and AV node, and this leads to decrease in the heart rate and it slows the AV conduction. Also, by decreasing the cyclic AMP, it decreases the calcium entry in the heart cell. Okay, by decreasing the calcium entry into the heart cell, it causes decrease the force of contraction of cardiac myocytes. Also, it causes the vasodilation. So how it causes vasodilation? We have already talked about that in the endothelium, let's assume that this is the endothelium, and we have in endothelium the AMP3 receptor. By acting on the AMP3 receptor and activating the AMP3 receptor, it releases endothelial derived releasing factor or nitric oxide from the endothelium, and this nitric oxide diffuse into the vascular smooth muscle. Okay, when this nitric oxide diffuse into the vascular smooth muscle, they activate the guanylyl cyclase, and this leads to activation of the cyclic GMP. And this cyclic GMP causes myosin light chain phosphate to convert into the myosin light chain. So it dephosphorylate the myosin light chain, and the phosphorylation of the myosin light chain is responsible for actin myosin coupling, and that leads to muscle contraction. But when this cyclic GMP dephosphorylates the myosin light chain, it causes no actin myosin coupling, and this causes relaxation. Okay. Then let's talk about the effect on respiratory system. So we have the AMP3 receptor in the bronchial smooth muscle, and that leads to bronchoconstriction, right? And it also increases the bronchial secretions. So these drugs should not be used in the patients with asthma and COPD. Okay. So we should not use, or these drugs are contraindicated to asthma or COPD patients. Then in the GI tract or gastrointestinal tract, we have the M1 receptor in the gastric glands, and that increases the secretions from the gastric glands, like it increases the acid secretion from the parietal cell. Then we have the M2 receptor, which is a GQ type of receptor, in the smooth muscles. Okay, in the smooth muscles, we have this M2 receptor, and in the smooth muscle, this receptor increases the calcium influx, and that leads to contraction of the smooth muscle. And we have the M2 receptor in the sphincters of the GI tract. and that leads to relaxation of the sphincters. So ultimately, these drugs increases the GIT motility. Okay, motility. If we talk about the genitourinary tract, we will see the same like in the GI tract, like in the visceral smooth muscle, like detrusor muscle. We have the AMP2 receptor, and it causes the contraction of the detrusor muscle. And in the sphincters, we have the M2 receptor, and that leads to relaxation of the sphincter and increases the urinary outflow. Then let's talk about the individual drugs. If we talk about the acetylcholine is not used as a drug because acetylcholine is readily or very fast deactivated or metabolized by the acetylcholine esterase enzyme. So it has very less plasma half-life, and also acetylcholine has a wide effect. So there is they can act on the wide variety of receptors. So acetylcholine is not selective drug, and so they have the wide adverse effect. Wide adverse effects. So acetylcholine is not used as drug. Then we have the bethanical. So bethanical is mainly act on the urinary tract and the gastrointestinal tract, and we use it in the bowel and bladder. In bowel and bladder conditions, like non-obstructive urinary retention, right? So non-obstructive urinary retention, like post-operative urinary retention, postpartum urinary retention, myogenic urinary retention, myogenic or neurogenic bladder. Neurogenic bladder. We also use it in post-operative adynamic ileus. Okay, adynamic ileus. We used it in atonic stomach, in ileus due to toxicity, and also in congenital megacolon. Okay, where we can't use the bethanical or contraindication of the bethanical, so we will not use if there is any obstruction in the bowel and bladder. So if there is the retention of urine or due to any obstruction, or if there is any there is no stool output due to any obstruction in the gastrointestinal tract, if we use this bethanical, this will increase the contraction of the this will increase the motility of the GI tract, and it will increase the contraction in the detrusor muscles. But there is obstruction, right? So if there is any obstruction and and the drug is consistently increasing the motility and increasing the constriction of the smooth muscles, but the stool cannot pass because there is the obstruction, but it will worsen the situation and worsen the symptoms for the patient because it is vigorously contracting. Okay, so we will not use in any obstruction or in the COPD patients or asthma patients because it causes bronchoconstriction. It is also not can't be used in peptic ulcer disease because it increases the ACL secretion and it will worsen the peptic ulcer disease. It should not be used in Parkinson disease also, and it should not be used in ischemic heart disease. Okay. Other drugs like I've talked about the pilocarpine, we use it in glaucoma. Okay. Other than glaucoma, we can use it to increase the sweating and salivation because these cholinergic agonist drugs increase the sweating and the salivation, and we have the condition called xerostomia, where there is a dry mouth or decreased salivation. So we use pilocarpine to increase the salivation in xerostomia patient. We have the condition called the Sjogren syndrome, which is characterized by dry eyes and dry mouth. Okay, so because pilocarpine can increase the tear secretion, and also the salivary secretion is increased, so we use it in Sjogren syndrome. We also use this drugs with mydriatic drugs to break the adhesion between iris and lens. Okay, with mydriatic drug. What are the side effects of using these drugs? As we have already said that it increases the sweating, so it leads to sweating, it increases the salivation, it will cause abdominal cramps, it can cause diarrhea, then it can cause meiosis, and it can cause flushing because it causes vasodilation, it can cause bradycardia by decreasing the heart rate, it can cause bronchoconstriction. So it should not be used in the asthma and COPD patients. So that's all for this video, and we will talk about the indirectly acting cholinergic agonists in the next video. Okay, thank you.